about all the things that have been discussed to date, which is absolutely amazing. So hopefully you're not too lonely in your place at home, and now can come back and enjoy what we are experiencing here. So our next two speakers are going to be talking about the evolving role of epilepsy specialist nurses prescribing mental health and care planning. And I'm just going to introduce them both and just tell you a little bit about them for people who don't know them. So, Nicola. There she is. Hey! So, Nicola's the Senior Children's Neurology Clinical Nurse Specialist at Hull. She worked there for 19 years. She's been a children's nurse since 2001. She is currently the paediatric lead for the Epilepsy Specialist Nurses Association, so ESNA. She's co-authored the transition section of NHSE's Epilepsy Bundle of Care, contributed to national policy discussions, and co-authored a book on epilepsy in children and young people. She's got lots of publications and has done quite a lot of work in collaboration with Epilepsy Action and Young Epilepsy. This is Carys.
Hello.
So Carys, again, works in Hull and is a children's epilepsy nurse. So she's been working as a paediatric nurse since 1996. She's an independent prescriber. She's been the CYP clinical lead for epilepsy across South Yorkshire and Bassetlaw. And she's built up an experienced epilepsy nursing team who continue to support children and young people in the region. So they're going to be doing a double act in this talk, and we'll do some questions right at the end, I think. That's great.
Okay, so we wanted to talk about the role of the evolving role of epilepsy nursing over the last 20 years at Hull University teaching hospitals, and also from a national perspective. But we're going to go back slightly as well before that. So an overview of our service in Hull. We've got a total caseload of children of about 440. We have a database, and sometimes we can, on a sort of month-by-month basis, that number will vary. There's about 60% of those children and young people have additional needs, from a complex disability to learning difficulties. We've got 3.5 whole-time equivalents working within our team, which works out around 125 patients per nurse. And we also work closely with 4 consultants. So the community we serve, so this is Hull and East Riding. We've got a little map there. There's over 126,000 children and young people from 0 to 18 years, 19% of which in Hull have an education, health and care plan and special educational needs, and about 17% of those in the East Riding, which a national average is around 18%. At Hull Royal, we have an emergency department and an assessment unit, medical, surgical and paediatric outpatient department. We also have on-site 3T MRI and neurophysiology, and we can have access to from standard EEG to sleep, and also a 24-hour telemetry, which is done on an inpatient basis on our high dependency unit and medical ward. So Hull has 4 teaching hospitals in both Hull and the East Riding. All the paediatric services are delivered from Hull Royal Infirmary though the nurses do deliver clinics at 2 children's centres within Hull, and also a community hospital in the East Riding. The nurses also deliver nurse-led clinics in the 9 special schools that cover our patch. We also have Saturday clinics to help out with some of our families that struggle, and we know transport and parking are both an issue at Hull Royal, as I'm sure it is for many other people. And we also have dedicated evening teenage clinics as well, which we started around a year ago. We also have a joint paediatric nurse-led clinic for we have 2 transition clinics. One is for children and young people with an intellectual disability, and one is also for the mainstream service. And depending on how many patients that we have to transition, that might be 1 to 3 clinics a year. So just going back a little bit before this, and the reason 1997 was picked as a date will become obvious, but certain things like Amazon was founded, Carys was top of the pops in the charts, Hong Kong was returned to Chinese rule, and lamotrigine was the newest drug on the market at the time. So the reason we picked 97 was because that was the year that my colleague, Christine Bennett, who has been an epilepsy nurse for quite a number of years now, commenced her role as a children's epilepsy nurse at Hull. and she was the 6th paediatric epilepsy nurse in the country at the time. ESNA had been formed about 5 years before that in 1992, so that's why we went back to 97. So there's been significant changes in practice since I started nearly 20 years ago, and also with the nursing role both locally and nationally. We've had the introduction of a VNS service in Hull, which is a nurse-led dedicated service. There's been the introduction and increase in the nurse prescribing, the management of prolonged seizures, in the introduction of nurse-led clinics, in the undertaking of nursing research and service development to improve practice both locally and nationally. We have a different skill mix and competence within our team. We have 1 learning disability nurse and 3 paediatric trained nurses. And there's been a greater amount of administration and tasks that are not particularly required by a nurse as well, which takes up a vast chunk of our time. Over that time, as we all know, there's been an increasing complexity of patients being supported by epilepsy nurses and a greater amount of family support required. There's a greater amount of more holistic approach for these patients and families as well, to also include transition and mental health. There's been an increasing reliance on us as epilepsy nurses to request investigations and become more involved in the patient journey from initial referral by undertaking nurse-led triage clinics, which Carys will talk about later. Nationally, ESNA's grown in numbers, and at least half of their membership now, which is around 500 people, are paediatric nurses. There's also been an emerging change in that the role demands epilepsy nurses that have an extensive and highly specialised knowledge to deliver the following functions: to deliver expert practice, professional leadership and consultancy, the development of education training, supporting with practice and service development, and research and evaluation. And back in 2000, the NHS modernisation agenda stated that they would like around 5,000 nurse consultant roles to be formed. And as of now, unless anyone's able to correct me, I think we only have 10 paediatric ESN consultants in the country. Nurse prescribing is an expanding role that we took on, and it's an extended role that as epilepsy nurses we have adopted or trained for. Nurse prescribing was initially nationally introduced back in 1998 as a result of the Cumberledge report and the first Crown report just after it. It allowed nurses initially to prescribe from a really limited formulary, and it was piloted with health visitors and also district nurses. So you had a very small number of drugs and lotions that you'd be able to prescribe for. Then moving forward into 2000, the government announced that they were going to extend the nurse prescribing role and look at a greater formulary and the increased amount of pharmacology training, allowing the prescriber to be able to prescribe from an extended formulary. Again, it was still very limited, and it wasn't very useful in managing children, young people with long-term conditions. The Crown report in 1999 recommended the setting up of two different types of nurse prescribers, both an independent and supplementary prescriber. So the independent prescriber could assess and diagnose, but for the supplementary prescriber, the diagnosis was already made and the assessment was completed by the doctor. In 2006, the independent nurse prescribing came into force, so that nurses were now able to prescribe from the whole formulary within the realms of their competency if it was approved by their employer. And nurse independent prescribers must only ever prescribe sort of within their own level of experience, and you've got to at least been qualified for 3 years and practiced in the area that you want to prescribe in for the last 12 months. So in terms of complex medications and non-pharmacological treatment options, as epilepsy nurses, we are required to support the monitoring of drugs, including CBD, bromide, fenfluramine and steroids, and we support the coordination of the tertiary level drugs as well when patients are transitioned over to adults at 16, because often some of the adult neurologists won't sort of fill the gap from that 16 to 18 year age, so we have to support them in monitoring those drugs. And we're also required to support the patients that are on ketogenic diet in monitoring and supporting families, and also training in schools so that the young people can be supported whilst they're taking the diet. In terms of epilepsy surgery in VNS, we support the management following initial implantation. Our implantation centre is Leeds. If you are under 16, if it's 16 plus, it's done in Hull on the adult wards. We have regular MDTs with the LeverNova that supports us and around drug regimes for the VNS. As I said, we run our own VNS service in Hull, and we have around 30 patients that are implanted. We also work with the reps, and we attend study days and also the masterclass, and we're able to download the data once the rep comes to see us and adjust those doses accordingly. And we also we have the special device in our MRI suite that we're able to turn the VNS on and off if patients are requiring MRIs post-VNS. So in terms of the management of prolonged seizures, epilepsy nurses formulate the seizure management plan, and that's with or without rescue medication. They can be often complex, I suppose, in terms of different seizure types and also different medications that young people use. We do have a cohort of patients in Hull that use rectal medication instead of midazolam. We also provide the training for staff that are in non-healthcare settings, so that's schools, social services and those sorts of arenas. And nationally, ESNA's also produced the buccal midazolam guidelines for the administration of buccal midazolam, and those are currently up for review, and there's quite a number of meetings at the moment to revisit those guidelines. We've devised a screening tool in Hull for supporting our young people with our mental health, and we try to assess this at least once a year. We do have a long-term health conditions team that covers both Hull and East Riding, but they have a very long waiting list, and currently both posts are vacant. Barnardo's did provide some funding to do something called the RAP project as a pilot, but this is also finished. So this is the checklist that we use. And we get our, as I said, we get our young people, and we use this checklist from 8 years of age as well. So transition, we used to have handover clinics when I first started in Hull. That's how I would describe them. It wasn't a transition clinic. It was you met the adult epilepsy nurse and you talked about the difference in services between paediatric and adult care, but there was no transition workup before this appointment. We sort of required some epilepsy-specific transition support prior to this appointment to ensure that the children and young people felt that they were supported and that they were ready for that next step. We used the Ready, Steady, Go transition checklist, but we found it too generic, and you couldn't assess that the young person actually understood the information that you were giving them at the time, and that they could actually provide you their guidance on what they'd understood. And in a 30-minute clinic appointment, you found that you were providing lots and lots of information to them, and it was almost like information overload. So we needed a better approach. So 5 years ago, we had an idea to produce some patient information leaflets following the Ready, Steady, Go format. We had a suite of 9 leaflets, 3 for young people with no intellectual disability, 3 for young people that had learning difficulties that was in an easy read version, and also 3 for parents of young people with moderate to severe learning difficulty. Over the course of the work I was doing with the transition work with NHS England, and also with the youth reps at Young Epilepsy and Young Epilepsy and Epilepsy Action, finally we were able to get some funding through Young Epilepsy and Epilepsy Action, and NHS created, digitally redesigned the leaflets, and we were able to finally get them launched on Epilepsy Action's website in August of this year. And the news got out, and so I was approached by Radio Humberside to be interviewed for the radio regarding the leaflets. So any health professional, young person is able to access these leaflets now on Epilepsy Action's website.
Okay, so a little bit of sideswipe. I sort of decided to focus on this. I've worked in Hull for about 18 months, and I'd previously worked in Bassetlaw for about 8 or 9 years. And this was something that when I went to Hull, the nurses there were doing the sort of triage clinic, or, you know, they were part of that initial triage process. And I was actually, to be honest, quite scared by this to take it on. But I observed what the nurses were doing and built my confidence, and then have become involved in that myself. And I then became aware that actually it seems to be a very good service, but also can be quite time consuming. There are a lot of positives to it though. And I guess I wanted to just look at some of the data and just see, how positive is this? And is this something, I'm sure it does happen elsewhere, but certainly I hadn't come across it before moving to Hull. So it was initially established, I think, about 6 or 7 years ago. Oh, okay, about 10 years ago. Initially, this was due to the pressures on consultant time, and obviously what we know about the NICE guidance and the KPIs within Epilepsy 12 is that the ideal is that anyone with a suspected seizure should be seen within that 2-week period, which we all appreciate is really difficult to meet. The other thing that the nurse-led triage clinic offers is that you're meeting the sort of team members very early on in the process. We can provide specific our contact details as a point of contact from there on in. We can provide appropriate safety netting. And one of the other things is obviously around prioritising those patients that we see. So this is an idea of the pathway. So the referral comes in from potentially the GP or our emergency department or the community paediatricians. The consultants then do their triage, which essentially the GP is the choose and book type service, and there is a specific epilepsy part of that. I think some of the seizures slip into a few of the others, so they sometimes take a bit of a diversion, but generally that's how they come to the consultant's awareness. They will triage. Normally then they just forward it on to us and include our admin and say, please, nurses to see. And that's how 9 times out of 10, probably more actually, we are seeing those patients first before anything else. Emergency department, they have a pro forma that they complete for any first seizure or suspected seizure. Again, the consultant will take a look at that and triage, and then we then see them in our clinic. Community paediatrics, sometimes it's just a form of a clinic letter or an email, but again, the process is the same. So following that, the consultant pathways started at the same time, so it's not like they see us and then wait for a consultant appointment. The consultant pathway is started at the same time, so they're on that waiting list to see a consultant paediatrician with a special interest in epilepsy, regardless. So then in the nurse-led clinic, we obviously do a full assessment, and from that we prioritise. So the way that we do that, we take the information to a weekly epilepsy team meeting, so that's the epilepsy nurses and the consultants, and we have a brief sort of summary of those patients, and sometimes a video, because we may have seen them and arranged to get that video uploaded onto vCreate, so we can kind of bring all that information together, and then decisions might be made about, okay, do we do an EEG now, although sometimes we've already requested it, is this urgent? Can this be prioritised, etc., etc.? So there's a few different things. Actually, how appropriate is this? And then the plan from there is investigations and obviously further triage from there on in, for example, to a neurodevelopmental clinic if that seems more appropriate. And then in the follow-up to that is, from our point of view, we usually would provide some feedback to parents if we felt it necessary at that point. For example, if we've decided to request an EEG, we'll obviously ring them up and say, we're going to request an EEG, and just give them a little bit of feedback from that. So like I said, I decided to have a little look at the data, service evaluation, audit, whatever we're going to call it. And why I decided to do that was to really look at the benefit. Who I was looking at, I sort of initially just started keeping a bit of a list of the patients that were referred in January, February 2025. So what are we going to look at? We're going to look at, did we diagnose? Did we request an EEG? Did we start treatment? And what were the differential diagnosis from that? And when, the dates and the timelines really of the patient journey or pathway. And where were we seeing them? Well, it's not an established nurse-led triage clinic. It was within the existing epilepsy nurse clinics, although before I started, when you're a bit short on numbers, you were doing one Saturday extra per month?
Every week. I think
every week?
We did 38 extra clinics in 1 year just for new patient referrals.
To see the new patient referrals. So, and then after about 6 months of me starting, you were able to stop that. But yeah, so that was kind of the additional work that was required at that point. Over the 2-month period, we got a total of 51 referrals in. So this is a bit of where did the referrals come from. 32 were GP referrals, 13 came from our emergency department. We had 1 direct from the ward and 4 from community paediatrics. Just a little bit about the patients that came in. So gender, out of the 51 patients, I think it was a 26-25 split. As you can see with the ages, the biggest age group was the 10 to 15 age group. And then next was the 0 to 5s, and the 5 to 10s being the smallest age group. So this was really looking at timeframes from the referral to that first nurse appointment. And you can see, obviously, I wanted to highlight that 0 to 14 days, which still obviously is not brilliant, but I think is good that within 2 weeks of that referral, we saw almost half of those patients. And then the next biggest number is the 14 to 30 day framework. So we saw the majority of those patients within the first 30 days of the referral. Just to note that in the 30 plus, there were, I think even the 3 that were there was at least 1 or cancelled by parents, and there was the other 2 were actually did not attend, and then we followed up and we got them in. And then there was 1 that actually didn't end up attending a nurse appointment at all, but did see a consultant. So this was the data from the nurse appointment to the consultant appointment. And as you can see, a few were seen within the first month, and some of that will have been that we were able to prioritise those that we felt were more urgent and get them seen. There's a lot in that 90 plus day group. I know that we had a new consultant come in April, so I think they were fairly short before then, and I know they did a massive catch-up. So we did, when we were looking at the data, we found all of them were seen. A lot of these were seen in 1 day. So I think, that was, but generally, as it was, January, February, and that 1 day was in May, wasn't it? Which is why I think a lot of them fell into that group. There's a few there, total did not attend. Some were decided that actually the patients eventually would have rung up and said, we don't need that consultant appointment. We've seen a nurse, we've had that discussion. Actually, we realise this is not epilepsy, and they've been seizure-free, they've been event-free or whatever. There was some inappropriate, one was seen in our paediatric assessment unit, and then, some were sort of diverted elsewhere. So what's interesting to note, I know we are privileged in Hull as nurses, we are able to request EEGs, and we have neurophysiology on site, so that's really helpful. Out of those 51 patients, a total of 30 had EEGs requested, 26 were requested by a nurse. So just an idea of what we do in our clinic is we use a similar model to what the consultants might use, obviously an idea about the events that have been going on, then a little bit more about assessment of that patient in general, their comorbidities, their learning, their birth history, trying to grasp all of that information in a 30-minute period, but there we are. What we don't currently do is any neurological or physical examination, which is, of course, what differs from a consultant appointment. But we do offer a safety net plan, and then we might signpost if we can, if we feel there's something relevant there at that point that we should signpost to. And like I said, we give our nursing contact details and a vCreate link if they've got a video, but we obviously encourage them to get videos. And as they have our contact details, once they have a video, they contact us, we can arrange that from then. So this is just a quick example of one of our patients on that journey. So the referral came in, it took 2 days from so it's a GP referral, 2 days for the consultant to triage, then on to 16 days to the nurse appointment, 25 days from the referral to the EEG, and then 33 days from the referral to the consultant appointment and starting treatment. And this particular girl was 12, and she had about a 4-year history, although the referral came in with a 12-month history, actually through discussion with her and her telling me. This had been going on for 4 years, these absences that have been witnessed by health professionals, I think potentially within the GP practice and at school, the school nurse, but I can appreciate this is difficult to assess out there. But they were thought to be non-epileptic for a long time, and because she had some mental health difficulties, they put it down to anxiety and behaviour that were causing these issues. So I did an assessment in clinic and requested an EEG, and actually the EEG captured one of her habitual episodes with generalised EEG changes. And at that point, we'd already discussed her within our weekly epilepsy team meeting anyway, and as a result of the EEG, her consultant appointment got expedited, and although there was only a 30-minute slot available, because a lot of the workup had already been done, that 30-minute slot was okay, and she got started on treatment. And she was seizure-free within about 3 to 4 weeks of starting lamotrigine. And 2 months later, she was back riding her horse and much happier in herself, and actually no longer needed the mental health support that she had previously required. So this was just a bit of feedback from the family. Were they aware it was going to be a nurse at that first appointment? Yes. Were they happy to be seen by a nurse? Yes. I think they were kind of like, well, it's a yes-no, so I'm going to say yes. Were you satisfied with the outcome? Yes. And were you satisfied with the process from referral to consultant appointment? Yes. And I appreciate this is one patient, and we do have a knowledge we need to try and get more feedback to support. And this was just the additional comment from the mum and her, in fact. I'd also like to say thank you, say the service and follow-up service from yourself and the team has been exemplary. So that's a real positive. I know they're not all like that, but we're always going to take the positive. So a little bit of a conclusion. So actually, out of the 51 patients, 10 were diagnosed with epilepsy, and their timelines varied depending on need, but also actually depending on patient and parent engagement, mainly parent engagement with some of them. Timelines were probably longer than we'd like. But 41 didn't have epilepsy. So some of the sort of differential diagnoses were shuddering episodes, stereotypies, reflex anoxic seizures, vasovagal syncope, tics, non-epileptic, and some sort of autistic overwhelm, zoning out, are just unexplained. The concordance with what the nurse sort of initially felt and what the consultants felt was around 94%. And additional extras, I guess, was we identified comorbidities and hopefully provided some support and some signposting. There's that early engagement and reassurance, and that's both from an epilepsy and a non-epilepsy perspective, because I think some parents got referred into the epilepsy pathway and then turned up and went, I had no idea. Why am I seeing somebody about epilepsy? So we could have that discussion. It's just the GP had done the referral to us. So we could have that discussion with them there and then at that point. And yes, sometimes diverting to what might be a more appropriate pathway for them. And this wasn't just, it's nurse-led, but it's through the wider team discussion. So other findings, I think looking at 20% of patients coming through actually ending up with a diagnosis. Does it identify a training need for our professionals, our GPs and our nurse practitioners within a GP practice or our emergency department staff? And that's, I don't know, because actually, again, it's easy for those working in epilepsy, who've worked with epilepsy for a long time, to make that judgment and make that assessment, but not everyone has that experience, so maybe it is appropriate. We identified how positive we are and how lucky we are to have the strong links we do with our neurophysiology department and being able to prioritise EEGs. Does it prevent attendance at hospital or attending emergency department? Again, I don't know. I can't prove that, but my feeling is yes, definitely. And just to note, so some previous data showed that between January and December 2024, Hull had 360 new referrals in, 71 confirmed with epilepsy. So that 20% stood then, so that my data kind of corresponded really with that data from that whole year. And what one of our consultants identified was that by us seeing them first, we reduced the amount of consultant follow-up slots by 250 over that year, because very often, rather than needing 2 appointments, they'd maybe only need 1. This is back to you, Nikki.
Thank you. So, having identified all that, looking forward to the next 25 years, what could it look like in terms of not just our service in Hull, but for services around the country? So there needs to be a continuous increase in the number of paediatric epilepsy nurses. There needs to be a development of the roles and also recognition of the gained competence, and the responsibilities should be reflected in our banding and pay. I'm trying to not be political here. Funding should be available for relevant courses needed for professional development. So there is no national funding for master's qualifications. There is no master's degrees in epilepsy at the moment in time. There are postgraduate certificates at master's level, but there is no funding to support those epilepsy nurses that wish to progress with their career. We also need to continue increasing in the use of technology to support our patients, and so we need to be kept up to date with all the technology that's available, as we're often the first point of contact for some of these patients. Nurses to develop the skills in neurological examination as part of the initial patient assessment, and experienced nurses continuing to undertake nurse-led first seizure or triage clinics. Access for all patients to specialist services and epilepsy nurses. We want to continue to remain active with local and national networks contributing to the bundle of care, and also NICE guidance, which sometimes ESNA often get asked to do, and also with the British Paediatric Epilepsy Group and ESNA. Want to continue to support Epilepsy 12 audit. Also, greater use of the community networking as part of the 10-year plan. And we're also looking at the development of dependency scores and looking at the ratios between patients and epilepsy nurses in relation to dependency and also responsibilities. There we go.
Thanks very much. That was a great overview of epilepsy nursing, where we should be going, and also very interesting, your nurse-led triage. I'm sure people will want to ask questions. See, the hands are up already.
Thanks, Nicola and Carys, and fantastic work. My question is that what proportion of epilepsy specialist nurses are confident that they are adequately trained for doing a nurse-led clinic? And the second thing is that what is the effect, because obviously the primary role of epilepsy specialist nurses to do the care plan and provide that support. So what would be the effect of starting doing that? And as you said, that obviously it needs additional work. What will be the effect on that?
I mean, yeah, I think it's an interesting one about experience and qualifications. Experience really as an epilepsy specialist nurse. Do we put a time frame on that? Do we, before we sort of let loose on that, nurse-led triage bit? But we haven't really established that, but it's a conversation, and I think we just accept that it's a level of experience. and understanding, and you're making that. And I think, but it's also important to note that, certainly I use a bit of a pro forma, and that we're taking that discussion further very, very quickly. So it is, although it is nurse-led, like I said, at that point, in a sense, it is the wider team looking at these patients. It's just a way of doing it. In terms of the impact, that's one of the reasons I wanted to do that little bit of data collection, to sort of highlight what we do, and also try and gain, does that then, I guess, take our work away from elsewhere? Nikki and Chris did overtime so that it didn't. But I think it would be a valuable piece of work for a business case to support needing greater amount of epilepsy nurses, so that we were still able to do the other stuff. And skill mix, depending on your banding and your role. Could you have are some of the roles that we already do, could it be done by support elsewhere? Do you know what I mean? So, yeah. Do you want to comment on that?
Yes.
Nikki?
I was just going to say that ESNA have also produced nurse-led epilepsy competencies over the last number of years, and again they're up for review again, which actually highlights the different skills that you would require at different grades of an epilepsy nurse, whether it be a band 6 as a junior epilepsy nurse, or a band 7 with your class as an expert, up to your nurse consultant. And that's the area that we're looking at producing at the moment, is for the nurse-led consultant. But as part of your nurse prescribing qualification, there is an element of assessment. There is an element of someone assessing that you are competent to be able to take a clinical examination, obtain a history from a patient, and to be able to make some sort of differential diagnosis, even though you're not diagnosing yourself, that you are able to think about what the differential diagnosis may be. So you do have that is part of your training when you undertake your nurse-led prescribing qualification.
Thanks. I think you were first. Wait.
Just to say, I'm a fan of the epilepsy nurses. I regard them as the jewel in the crown in our service. But I also don't want to flog them to death, because, it's better to be focused and do what you do well, rather than try to do all. I had to step out. I was really impressed that you do Saturday clinics, because I'm sure that teenagers need that. They miss enough school as it is. I heard that you are involved with transition, but we used to do a handover clinic and realised there's more to it than that. So we do Ready, Steady, Go, and our nurses are doing that. I just wondered if you had a comment on that. We've also sort of been agonising about a sodium valproate database and making sure that we're MHRA compliant, and we're going to lean heavily on the epilepsy nurses to help us with that. But it's hard to pick and choose where to use you. I just wondered what you were doing about valproate and the more longer transition path.
Okay, so we have a sodium valproate. It's not a database, it's an Excel spreadsheet, because I'm not very good in creating these things. And we actually run, was it about 4 sodium valproate clinics last year to initially identify all the patients that were on sodium valproate to start with. And then in place of our teenage clinics, we had evening clinics that were for patients with sodium valproate, so that we could provide the information and go through the checklist with them in supporting with the consultants. In terms of the transition, we do the evening transition clinics, which again we started around a year ago, and we use the leaflets that we designed, which were on the Ready, Steady, Go pro forma. And so we use those in clinics, and we tend to give them prior to clinic, and then say to them, don't just put it in a drawer. You're going to be quizzed on this booklet when you come to see us in clinic. So we'll often have 3 key questions that we may ask them. So it could be, what's the name of the drug that you're taking? How much are you taking? How often do you take it? And even something like, are you remembering to take your medication? Do your parents have to support you? And then we'll give them sometimes 1 or 2 tasks that they have to perform for the next time that they come to clinic. And the 3 booklets are designed to be given, which I haven't alluded to before, they're designed to be given a year apart. So that's sort of 13 age, then 14, 15, and then 16 prior to going to transition or going off to college. And the information in them is very different to each. So that's how we get around the transition. And I'm really sorry I forgot the first question you asked me.
Okay, just before we move on, the brochures, are they free from Epilepsy Action?
The downloadable.
The downloadable, because one of the problems, well, maybe it's just a problem in Scotland, but we can't print in colour. So, because it's really...
We have trouble as well.
Yeah. Okay, so they're downloadable only, they're not posted out.
No, they're not posted out, but they're
Okay, thank you.
downloadable.
If I go online, there's quite a few questions online, so sorry if we can't get to them all, but a popular one was, what evidence did you use to be able to allocate 125 patients per whole time equivalent? I think a lot of people are saying that they have a lot of caseloads and a lot of patient population, but struggle to get the resource.
There was evidence.
I think is that not in the NMC guidelines?
As far as I'm aware, that for paediatrics, there is nothing that specific. I think there's banded around for adults 1 to 250, but I think we are fortunate, and I do see that in our caseload. But that allows us to do some of the additional things. So although Nikki and Chris did that, a clinic every week, however, they don't do that anymore. This is all. So they managed to kind of get me in. But the other thing was, I think when the pilot program went out for epilepsy nurses, the NHS England as part of the not the bundle of care, what am I thinking of? We call it transformation program.
Yeah.
Hull actually got allocated some money for that, and they used that for transition. So that was another way of getting me in. They were able to use that funding, and they sort of muddled with it a bit, and they were able to use that funding. But what it then highlighted was the need to keep the numbers up. So that's why when I was able to tell you about the 250 consultant slots saved, what happened at that point was one of our consultants actually took that to a higher level to say, this is potentially what would a consultant cost at this point, therefore can we use that funding? So I think it's just about being smart and understanding, it's not just a case of numbers, it's what are you doing to kind of manage your money. Yeah.
And if you're able to publish that in some way, because this is what the policymakers want to know, isn't it? How much money can be saved by these sort of innovations, quality improvement in practice. And as you say, I know I've worked very closely with epilepsy nurses over years, some of the jobs that you do in your epilepsy nursing role don't need to be done by a band 7 nurse. And just thinking about the skill mix, I think, is really important, isn't it?
And that's what we were trying to allude to often now on a daily basis. And I've had this discussion with Colin recently, that some of the roles and tasks that we do, like chasing up prescriptions for patients, I have a parent that will ring in to say the GP's not got the letter. That could be done by someone other than, as you say, myself as a band 7 nurse. So there are roles and responsibilities that don't have to be, or could be managed better, and our skills could be allocated to those other resources that will have a bigger impact on the patients and families.
Thank you. Another question from online.
Yes, it was about the role of epilepsy nurses in the community as well. Do you think that could be kind of tying into what you've just said about using your money better?
As in, what is the role? What is our role within the community?
Yes, or like how we could better make use of that role.
I think, we are based obviously in the acute trust, but we are community focused as well, in that we do outreach clinics and within the schools already. So I do think we've got quite a good balance of it not being too acutely orientated. I think at the moment.
I'm also involved in a special school MDT. So some of my work on a 3 times a year basis is working closely with physios, OTs, dietitians, social workers. And it's definitely beneficial, so that they'll contact me and say, we've got a list of patients, Nikki. So many of these patients are yours. Are you able to come to the MDT? So it's not just about the epilepsy. It might be about they're waiting for a gastrostomy, which obviously will have an impact on them if they're not able to take the medication orally. Is it having an impact on the seizure frequency? So it does help working in community, because you get to see those professionals that are, whereas before they were working in silo, that we're now working as an MDT. And when I first started in my role 20 years ago, we were based at a child development centre until the tidal surge hit, and then unfortunately we were thrown out. Not literally, but it meant that we had a social worker that was down the corridor that I could say, if I'd got a safeguarding concern about a patient, I could go speak to. So I think it definitely has a beneficial impact to be able to work with other members of the MDT out in a community setting.
Thank you. So I think last question in the room. Oh, we're going to go to Colin. Last word from Dr. Dunkley.
Thank you. That's it's really encouraging, and it's nice to see innovation. It's challenging, isn't it? And I like the fact you're going upstream. You know, you're trying to almost see children before we traditionally see them. Similarly, locally, I'm trying to do some work using community diagnostic centre funding and capacity, and we've just had a business case agreed for not an epilepsy specialist nurse, but a seizure specialist nurse, and hope to do what we're going to call enhanced triage, and it's remarkably similar to what you're describing. So two questions. So in that work, we're trying to look for not just later reduction in activity, but reducing ambulance and 999 calls. So have you got a sense of reduction in that sort of acute ad hoc signal because you're getting in there earlier? And my other question is, do you worry that you're going to see everything but epilepsy, given that, you know, children with seizures who don't turn out to have epilepsy are probably 2.5 times as many as those with epilepsy? So any thoughts on those two things?
Yeah, in terms of, you know, are we reducing attendances at hospital and return for that? I think we have to look at the minute, I can only sort of comment on maybe some of the patients that I've seen. So an example would be a lad who was having regular generalised tonic-clonic seizures, and he'd been to, I think, our emergency department at least twice, and then I saw him, we got him an EEG within 2 days, got him started on treatment within 2 weeks of me seeing him, and he was seizure-free. So had he been waiting, and actually he did have a focal cortical dysplasia, but had he ended up being waiting in that pathway, the reality is more likely it would have been 2 to 3 months. Now, he may have come in a different route. He might have ended up on the ward and then started on treatment. But I think in the minute, that's all I can comment on. You know, those kind of patients we are prioritising because we see them and we are aware of the severity of their episodes and what the impact of those are. So that's part of that triage. But we've got no way of actually saying yes or no. But other than that, really. What was the other question? It was about...
Do you worry that epilepsy nurses are going to become seizure nurses and see everyone except those with epilepsy?
And I think that kind of already happens a little bit with non-epileptic episodes because, you know, we see them and then we kind of identify the non-epileptic, but they've already formed that relationship with us. They have our contact number. They go to our emergency department and somebody there can say, oh, they're known to the epilepsy team. So then they come to us. So that's already happening. And I think that's part of the wider picture of how do we manage non-epileptic attacks. But because Nikki is a neurology nurse specialist, as opposed to not just an epilepsy nurse, but you know what I mean, we already have access to Nikki. So for headaches, tics, and sleep issues, we already have a nurse who can accommodate some of that.
And I guess it's parallels with what we do as well, isn't it? That we see coming through the door a wide range of things that are not epilepsy and sort of have to sort and sift, don't we? So it probably has a lot of similarities, doesn't it? Whether you're a secondary level or indeed tertiary, seeing secondary level patients as I do.
well, one way or another, we need more specialist epilepsy nurses. So thank you. Thank you very much.
I think that's the message. Okay, thank you so much, Nikki and Carys.